Hey guys, welcome to another great episode of the Best Practices Show podcast. My name is Kirk Barron. I'm your host, where you can find all the great tips, tools, advice, thought processes, just great energy on how to create a better practice and a better life. And today is no exception. You are really going to enjoy this. I've got two of my favorite people in all of dentistry, one of my mentors, and then a new mentee or friend, or now he's even trying to coach me, which I think is working really well. And you guys will absolutely enjoy this. So do me a favor, grab a pen and hit the share button. You will absolutely love this. Now, if you're joining us for the first time, I want to do two things. Number one, I want to thank you for showing up to a great community of people that are just committed to learning. Keep showing up. We're going to bring you great tips, tools, advice from great key industry leaders and just help you create the practice that you've always wanted. The second thing I want to do is I want to encourage you to subscribe wherever you listen to podcasts, whether that be Google, Stitcher, Amazon, I listen to iTunes, wherever you do listen to podcasts, make sure you subscribe, because you'll see every single week we're going to be bringing you great stuff that'll just help you all the time. And then I encourage you to share it with your team. So a lot of times dentists do a lot of listening to great stuff, but they never share any of this stuff with their team. You have a great resource, a great asset, and they're called the people around you. So share it with them. And then lastly, we take a lot of notes. So as you're going to see today, we're going to be sharing a lot of tips, tools, specific links. I'm going to talk about John's podcast, a book that he's got coming out, and you'll see there'll be links to all of this in the show notes. So I'm going to encourage you to come back and visit the show notes wherever you're consuming the podcast so that you can get all this information. So, and most importantly, I just want to introduce the two people that are on with me today, great friends. And I love this. You guys we were talking about this before we went live. This is probably my favorite thing I do all day long. And it's kind of cool for me because I'm in the middle here. I'm sandwiched from a mentor, and then I got a great friend, behind me, and I'm kind of the middle guy now. And I feel like Bill Robbins, who said years ago, he's like, Kirk, don't blink, because you're going to be the youngest guy, and then you're going to snap your fingers, and pretty soon you're going to be like the oldest guy in the room, and enjoy every step. So I got my good friends, Dr. John Cranham and Dr. Kevin Groth, and I'd love for you guys just to introduce who you are, because I always like to know, or I like people that are listening to know who we're talking to. And we're going to be talking about the digital dilemma today. So who wants to go first?
Kevin, have at it.
Funny. Well, I'm Kevin Groth, restorative dentist out of Detroit, Michigan, and born and raised in Michigan here. Excited for football season to get back because we finally have something to root for. So that's a great thing. And really ACT client for a couple of years, also Dawson Academy guys. So really it's kind of fun to see on these screens two people that have had a huge influence in terms of my career and what I do on a daily basis, both professionally and personally. So it's kind of an honor to be here. You can call me a mentee, Kirk. I'm not offended by that whatsoever. So always learning, always happy to be here, and just excited to hop on for this podcast again. So have at it, John.
Yeah, I'm John Cranham. I'm a dentist. I've been practicing 32 years now, which, like Kirk said, I went from the young guy to the old guy so fast. It's kind of crazy. I'm the past clinical director at the Dawson Academy, still involved with that organization, but much less, day to day, which has been really, really nice. I have a new partner in my practice, my daughter, who's just left dental school. So probably the primary reason that I've let go of some of my other responsibilities so I can be with her. And, I consider myself a dentist first and educator second. But I've loved my time in dental education, whether it's teaching or hands-on or lecturing or writing or whatever. But first and foremost, I'm a husband and a dad of three great kids, and worked hard my whole career to kind of honor what Dr. Dawson taught us a lot about, which is kind of keeping this all balanced. So anyway, I'm excited to be here. Love these two guys, and let's do it. Let's talk about the digital dilemma.
Let's do it. Now, I want to talk about the why before we get into the how. Because this is a big conversation in dentistry, and everyone's talking digital. Very few are making the full conversion, or some of them are. I mean, I'm still going into offices and they say we're paperless and there's paper everywhere. So why is the digital dilemma such an important conversation? And John, you've seen the whole evolution. It's changed faster in the last 5 years than it probably has in the last 20, but what is it and why is it so important?
Well, I think that when we look at anything technologically, I think the first and foremost thing we have to evaluate is, if we go digital, can we at least do it the procedure, whatever we're doing, as well as what we were doing in an analog model. So that's the first thing. Because I do think there were some early adapters to digital that got so excited about digital. And when you really evaluate it, and I'm talking about, 20 years ago, that first generation CERAC, it would mill out inlays that would go into the tooth and like rattle around. It wasn't even close to what we could do in the analog world, but there were people that jumped onto that were important for what we do. But for me, if I'm going to jump into digital, I want to make sure it's at least going to be as quality wise as good as what I could do in the analog world. And then the second thing is it at least as efficient? Like, is it going to, I mean, it can be as fast as what I was doing. And what you hope is that when you jump aboard, that both of those things are going to improve. So if it allows you to be more accurate, more consistent, more predictive in what you're doing, and create efficiency, well, now you have a real reason. And so for me, I was one of the early adapters to CERAC when it went to 3D. And then I think I was the 6th user of the E4D. And that was, in sort of that chairside CAD/CAM world. And I jumped into both of those because at the time I was teaching with Dr. Dawson, and he saw so many doctors buying these things. He wanted somebody in the academy to be able to talk about how it fit in complete care dentistry. And so it cost me $100,000, but I did that for Pete and got it and really worked through how we could do it. And quite frankly, it really wasn't that different in how we approached patients, because when you get to restorative dentistry, the mouth is already biologically and functionally stable. So a lot of times we were working on equilibrated mouths already. So CR and MI was the same thing. We could do single crowns with it and things. So that was sort of the first step into it. But what I got really excited about early was I saw the possibilities of being able to scan mouths more for diagnostic purposes and be able to do wax ups, and then, have some way, we didn't have printing back then, but there's some way, visualize some way to make a model and be able to get away from mounting. And we're there now. We'll talk a little bit more about the software we're using, but, for instance, the diagnostic process 2 years ago in my practice, when we do a face bow, a centric bite, and pour the models, and it would go to my son, and he would spend a day mounting everything and making it beautiful and come back to me. It was 48 hours before I could do what I wanted to do to it. Well, he has it mounted before the patient even leaves. I mean, there's no stone, it's virtually mounted, and I'm already looking at the slide. And I still think it's good for the patient to come back for a separate consult, but it's certainly in a realm of possibility where if the patient was coming in and wanted to wait a little bit, we could have those conversations, within an hour of the appointment. So, as I look at it now, the possibilities of not only doing chairside CAD/CAM, which I think was the entry level of where digital went, it's now evolving so far past that into what we can do diagnostically. And my personal hope is it's going to make the ability to be able to visualize optimum dentistry and design occlusions and design beautiful smiles much more attractive to the mainstream population of dentists, because it's not going to be as difficult. And you're not taking wax bites. There's so many things that are out of the way that created obstacles and, quite frankly, inaccuracies. And then when you start even looking at implant dentistry and all these other things that are coming, orthodontics, it's just moving so fast right now that, I'm a big proponent of believing that the things I was dreaming about 15 years ago are here now and starting to evolve at warp speed. And I, honestly, from that standpoint, I don't remember a time that I've been more excited about just day-to-day dentistry because of all this cool stuff I'm playing with.
That has to be so neat to see the evolution of things as ideas and concepts that didn't quite work to now being fully implemented. I remember you did a COVID conference lecture on this, and it totally changed my entire mindset towards that. Because for a while, as a new dentist coming out of school, I was thinking, well, yeah, I could take an impression digitally, or I can take an impression with the analog traditional version, but I mean, it's going to do the same thing. But when you did that lecture of all the possibilities of being able to do digital face bows and wax ups and seeing if you need to equilibrate or if you need to add or orthodontically move teeth and change the shape and design of teeth, it just kind of opened up every possibility that you just can't do with the traditional ways. So, I hopped right in. I called up Trios and bought a scanner right that day. So to me, it's something that I've found that the transition has been pretty seamless and it's only growing, but I would love to get into that discussion of the things that people underutilize, because I don't think people really realize how much and the capabilities that you could do in a pretty, not effortless manner, but it's a lot easier than what you expect it to be. Would you agree?
Tonight, yeah, I agree. And tonight, actually at 7, I'm doing a webinar through the Dawson Academy, and it's basically treatment planning all on 4 type cases. And it's just as an example, I show a protocol that we've used for a long time, where in the analog world, we would take a set of models, diagnostic models mounted, and we would put little dimples on the cast, kind of up in the gum area, and then they would duplicate those models and duplicate the mounting. So we'd have two sets of identical mounted casts. On one set, then they would do the diagnostic wax stuff. So you think about the whole process of that. Once they would get there, they would go ahead and scan the pre-op models, scan the diagnostic wax up. So when they aligned those in space, they could line up the dimples. Now, the purpose of that is they would take the pre-op model and overlay it into the CPCT, so they could actually bring that model in. And then they could take the diagnostic wax up and overlay it on the little dimples on that one. So that was quite a process. And the whole purpose was so that you could see on the CBCT where you wanted the teeth to be at the end. So when you virtually place the implants, that you could make good decisions. Well, tonight I'm going to show that process, and I'm going to show it doing digitally. And in the digital world, that whole time frame of taking that pre-op model and then doing the diagnostic wax right over it takes 15 minutes. So I now have in 15 minutes have all of that data that will go right into the CBCT. And so the time savings, and I also think the accuracy of it, because when you try to duplicate models with dimples on it in the analog world, there's just a little bit of an inaccuracies of it. And so what I keep finding is just more and more ways that it's saving time and increasing accuracy. Same thing with making splints and things like that. Been able to use a splint design studio. So kind of goes on and on, but one of the things maybe we can get to down a little bit, and I'm really interested in hearing you about this, Kevin, and I'm having this conversation with my daughter, is she is learning a lot of the digital things that we do, but what I'm realizing is that I have like all this experience, which is a nice way of saying I'm old, but I have all this experience that's analog. I've spent, I can't imagine how many sets of models that I adjusted on stone before I went to the mouth. And when you can do it rapidly in a digital environment, it's different than when you go into the mouth and adjust. So maybe you can comment on that. Like if you're thinking about how you learn, because you went through our protocol and learned in the analog world, do you think you could have had the same experience learning it all digitally, or do you think having some of the analog experience is important?
I think the analog is so important. I know it's old school or whatever you want to call it, but to me, you're able to think critically when you have the analog version of things. If it's just done it for you digitally, you can't really see the process and the protocols and the work that goes into how this all happens. So to me, having the analog ability, now you can take a digital and say, how can I make the digital fit in line with what I did better or efficiently or faster, whatever you want to say. And my associate, she's going through the Dawson Academy right now, and she's doing the same thing with all the analogs. And then eventually, we will replace a lot of the stuff we do on an analog level into a digital realm, but you cannot replace the experience of doing something analog. And I think
I'm going to record this. I'm recording you right now. I'm having this conversation almost every day with my daughter. I'm the Xbox generation, that kind of
sure.
Stuff. But the point of it is when you get to your patient, your patient's 100% analog, right?
Mhm.
It's analog. I mean, you've got to do it with your own hands. And so when you're adjusting a set of casts on an articulator, you're using with a handpiece, you're using the same brush strokes you'll do eventually in the mouth. Whereas if you've got a little eraser and you're adjusting an incline on a computer, like I can totally visualize what I'm doing because I've done it so many times.
Mhm.
And I think when you're learning it, those brush strokes on stone models or printed models are important. That's what
It's really cool when you start adjusting models and you just do a little bit of an adjustment here, and all of a sudden all the context comes together. You really realize how little you have to really do in order to make that happen. But you cannot do that in a digital way. There's no way that you're going to be able to.
Well, you actually you can see it. I can see, you can see how fast it closes down, but I'm worried more about the brush strokes, like learning where the inclines actually are. Like, even though you can see it three-dimensionally, I don't know. But I agree with you. The thing
restoratively though.
Huh?
Restoratively though, you're still going to be doing provisionals and you're still going to be doing finals, and you might get something back from the lab and saying,
I'm
the
talking
lab totally jacked us up, but yet
I'm talking more about a straight up equilibration.
Sure.
Yeah, straight up equilibration. But again, I do think that and again, what you're saying is also what laboratories say. You know, if you hire somebody who really knows computers but has no real laboratory experience waxing and casting and grinding on porcelain, they tend to make beautifully over contoured crowns. Like they can't, they sort of trust the computer. Mm-hmm. Whereas if you take somebody who's done a lot of analog waxing and teach them how to use the computer, they're usually the best digital designers. So I think it's the same. I think, which is interesting.
Well, let's go a little bit deeper in the eye of the hurricane, because you mentioned digital dilemma. What is the dilemma? Like when you say, and you said, we talked about a little bit about why should and shouldn't a dentist consider digital? What's the dilemma? And let me hop over both of you. I'm going to be a 24-year-old kid coming out going, I know you had phones on the wall and all that kind of stuff and videotapes, and then you had a cassette player. And then I'm telling my kids about an 8-track and they're like, sounds great. Like we've got that going on too. But let's go to the first thing, like the digital dilemma. Why should or shouldn't a dentist?
I think the biggest dilemma for people is the cost. I do think that, particularly some of the people that are my age or a little bit older, like I was having a conversation with Glenn DuPont about it. And Glenn has the same scanner that I have. And here he is 67 years old and sort of jumping in. But, if you ask him, he's doing a lot of the nuts and bolts things with the scanner. But a lot of the bigger things, he's just not going to leave the way he's always done it. And why should he? He's got it down. It's work. So he kind of has a practice that I would say is a mixed practice between analog and digital, which is fine. And everybody gets to figure out at what level that they want to go into. But, for a lot of doctors, I think they look at the price of a scanner. And what's interesting about scanners is the price point's sort of all over the place. I think there's scanners that are in sort of the $14,000, $15,000 range, and they go all the way up to 50 to 60, depending on what bells and whistles you get. And what you have to think about is, first, when you're comparing, make sure you're comparing apples to apples, because some of the scanners that are cheap may also charge you each time you use the scanner. And so that's what, and I don't think 3M does this anymore, but their scanner initially came out with that because they wanted to have a low price point to get you to get the scanner. And what they were concerned about was losing the revenue from their impression material. So their business model was to have a similar fee from the impression material. And I'll never forget that, because I was a key opinion leader with them. And when I was in the room when they were talking to these 3 like 30-year-old guys and under from MIT that had this scanning thing that they were going to use in some venture, and then they saw dentistry, so they started adapting it to dentistry. So we were up there at the as a key opinion leader at Wanawak, and we were looking at it and seeing their first scanner, And then I hear the number $100 million being thrown around, and that's basically what these three young guys were going to sell their technology to 3M, $100 million. And these guys weren't even 30 yet. And so I remember asking one of the top guys in 3M, I can't remember who it was, I said, so why are you spending $100 million? Why are you giving $100 million to these three guys from MIT? And he goes, well, because we make $700 million a year in impression material, and we're afraid that we're going to lose that revenue if we don't get in this game. So their idea was lower price point, charge per thing, so that impression material is expensive. That's the other thing I want you to think about. What if you bought a scanner and you weren't buying impression material anymore? So one of the things you have to look at is, what are you spending? Most of us have no idea what you spend a month on impression material. We looked into it, and I was spending anywhere between $400 and $1,000 a month in impression material. Well, that pays for a lease on a scanner in a freaking heartbeat, And so I started to take away the money aspect of it when I realized some of it was going to go away, just by not utilizing certain, Improgum or whatever I was going to use. And then other price points are, you're going to pay more, but you can have unlimited use of the scanner. You also want to consider, accuracy and all that. But quite frankly, all of them now that are still hanging around, you want to just get the one in your office that feels good, that you feel like you can scan pretty rapidly with. And so that's what I would do, is I would just have them bring the different ones into your practice and try it. And I think the price points of all of them sort of kind of will equal out after a while. I don't think that's the biggest consideration.
Yeah, it makes some sense. I think another reason why I went Trios would be the fact that they say you don't really have to buy a unit for a long time. We just upgrade the software, which I appreciate that, because it's like buying an iPhone every 2 years or a year or whatever it is. It's just, I didn't want to make the investment and have to buy a whole new setup of things. But there are some limitations to every single thing. So like you said, bring them into your office, try them all out, see what the pros and cons are. And there are some cons.
I think right now the three biggies that I look at, I think CareStream's a good one. I think Trios is a great one. We use the iTero and love it. We actually have the CareStream coming in now because we're getting their new CT. So we'll have two different units, but the bottom line is, I think that's what everybody gets stuck on, is the cost. And then I think the second thing that people get stuck on is maybe they're not that technologically savvy. Maybe they're not that, they don't like the buttonology, and then that is a good reason. If you're nervous about it, I can tell you though that in terms of the scanning part of it, I hardly touch the thing. I mean, I really don't. Can't remember the last time. I'm not sure I know how to take a scan. Maybe that's bad, but they come in, they train the assistants, and I'm certainly all over the scans when we're looking at our preps and things like that. But I think that's probably the two is how technologically savvy are you? If you don't like technology, then, and you're a little bit older, you might be apt to stick with the analog way. But if you're younger, I just don't think you can ignore what's happening, because things are moving so rapidly in that direction. And I think you're going to be left behind. And for those of you who listened to me before, I have that acronym PEP, predictability, efficiency, and profitability. And I just don't think there's any way around. I think you're going to leave predictability, efficiency, and profitability on the table if you don't start getting into this game.
Yeah, those are principles that. Oh, go ahead. You go.
Oh no, I was just saying, you gave some advice to me or to the community when we were talking about single units in terms of capturing an accurate impression. And I think that's an important one that maybe share. There were a couple pearls that I can think of that you said. I'm sure you're going to hit on those, but I think it would be really valuable for people to listen.
I want to test you. What did I say?
Well, one, you said you have to have a good prep. If you have a bad prep, nothing's going to work. But two, it's also capturing it. If you don't have correct isolation, if you don't have correct packing cord, all those different components, it's not going to work on a traditional impression. It's not going to work on a digital one. But the thing that I really took away was when you do pack the cord, you don't have to shove the cord all the way down to the depth of the sulcus. You're basically, with digital versus analog, is the digital, you're just pushing the gum tissue out as opposed to trying to get the PDS.
That's right. So what I always say is you want to have an impressible prep, which means you have to have a clearly defined margin. However you do it. I remember I used to teach at the dental school with the juniors, and they do those first crown preps, and the crown prep would go like knife edge, chamfer, shoulder, chamfer, knife edge. It was like not a clear margin all the way around. So it's really tough and I would sit down and show them that concept. Start with an impressible prep so that when you're looking at the impression, whether it's digital or analog, you could see whether you got it or not. And the big shift, and again, it was sort of a paradigm shift for me, but I was so used to having a double cord technique with traditional impression material, because you'd put two cords in, pull the top one, because you wanted to be able to get the impression material past your margin. So you're packing the cord much deeper. What you realize with digital is you can't see, it only sees from the top. So it really doesn't see the vertical walls of the root. It just sees what's kind of straight down in it. So, putting in one bigger cord that just pushes the tissue away, as you said, so that from the line of sight, you can see the margin. That's what's critical. And I do think too, utilizing another piece of technology like a laser or something like that, sometimes imperative, because sometimes the tissue just wants to creep over. And you might have to take a little tissue away to get that line of sight. But those two things, again, do increase efficiency. And I do think it makes things a little more predictive, because double cord techniques on some of the lower crest situations on patients, there's no question that contributed to recession on some of your, you'd come back and take the temporary off and you can see your margin, and you were subgingival before. So not having to be quite as aggressive with the tissue, I think, is a benefit.
Yeah. And going back to your acronym, which I love and I use almost every single day talking to dentists, the first one is predictability. The higher the level of predictability, you never talk about the cost of stomach lining, but if anyone's ever been through, the whole gamut of training an assistant to do great impressions, send them out, the whole process. Now, the other thing too, this is stuff that I love. John, you taught me this years ago, sitting on the other end of the prep, when you're in a dental chair, the drill sounds a little different. You know what I mean? Like drill coming at you, like, wow, I've never heard it that way. But I'll just say, as a patient, I've had all that in my mouth and gagging and then they go, oh, we got to do another one. I'm like, oh, thank you. I was looking forward to that. And now being an Invisalign patient, where I go in there and boop, 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 there's no question benefit to patient. Which one is better? And then I always say this, I'm sure you do this too. When you're talking to an audience, when you're physically with, how many of you have digital impressions? And then there's, how many of you love them? Like their hands go higher. And why do you love them? Because they're great. I go, why? Because they're predictable. Like how predictable? 99.9%. It's pretty cool to watch this whole thing.
And that's the thing. I mean, when you think about an analog impression, you're looking at one area, and it's amazing how, as a dentist, if it's kind of there, how you can talk yourself in that the margin's there, right? Like you can talk yourself into it. And, it's a bummer when the lab calls you and says, it's not there, if they call. Sometimes they've got the margin maker that just will invent a margin for you. We've all had that. But when you're scanning and you flip that thing around and you can make it as big as the whole screen, there's no guesswork. I mean, you can tell where the margin. I literally my last case was an 8-unit case that I did before I left today. And we lased, it was lower anteriors back the first spine. We lased, and when I was looking at the scan, there was one tooth that the tissue just laid over. I just couldn't clearly. Now, if that was an impression, a traditional impression, I may have seen it, I may have not. Probably would have seen it, and I would have redone the whole thing. But with this, all we did is we just cut that one little tooth out, and she went over the tooth again 20 seconds later, and I picked it up. So a little pass with the laser and rescanned that one tooth, and we're done. Now, how freaking cool is that?
I think that's the best part. Is that
that is like
cut it off and then just recapture it. It's just so fun to be able to do that.
And the patients are like, what?
Wow,
So,
right?
yeah, so there isn't any question that, and back to your Invisalign analogy, and I can't remember what, I heard the statistic that they were, when they, and again, you think about a company like Invisalign buying iTero, right? Like making that purchase to have a scanning company. And the reason they did it was because they were, I think it was something like 8% of the polyvinyl impressions that they were getting in, they were rejecting. It was a high number, maybe it was 5%.
Wow.
And with scanning, it's way less than 1%. So for them to be able to, you think about the monkey wrench that puts into their business, that if they're having to kick back work, and so if they kick back, what if the patient now says, nah, I don't want to do it now? Yeah, that probably happened.
Yeah.
I don't want to go through all that impression.
We
If you
even
can't get it
saw,
right the first time,
yeah, we even saw it a couple of years ago. Some of the biggest labs were purchasing these machines for their highest producers because it
Same
was a flow of accuracy going back and forth. If a dentist did a lot of volume and didn't want to do it, let's purchase the machine, reduce the amount of remakes. It's great.
Yeah.
Talk about the communication aspect of things or education for the patients. I think that's a big positive that I've seen in my practice.
Yeah. I mean, one of the things that, just from the standpoint of, I guess just the cool factor of being, embracing technology and creating an experience that the patient hasn't had before. There isn't any question, both photography and then being able to do an intraoral scan and being able to quickly take a patient on a tour of what you're seeing. You add that in with something like the T-scan that gives you the, the force maps and things like this. But it doesn't take much. For instance, if somebody's missing 2 lower molars and you just take your bite and maxillary cuspation and then you do basically the force map on it, and they see all the forces on the teeth on either side of it and then where the hole is, it's a really easy discussion to say, Mrs. Jones, you've been missing these teeth for a long time. I've seen some wear, there's a crack here. And one of the things you have to understand is if this tooth is missing, these 2 teeth are now carrying the load of their own job and the one that's missing. And that's just a really simple example of getting people to understand that they don't have 28 individual problems in the mouth, that this is a system that's designed to work together. And if you're missing parts of it, it creates problems with the parts that are remaining. So, yeah, one of the things that we've really pushed is whether the patient comes in to see me first, or if a patient comes in and sees the hygienist first, which sometimes happens depending on how the call goes and all that. But my hygienists are totally comfortable scanning. So everybody that comes in gets scanned. And yeah, and so if they get scanned, whether it's Caitlin and I are walking in there, then it's cool to have a photo on the screen or a couple photos that we can talk about, and then we have the scans that we can look at, and that creates we're not necessarily selling dentistry or talking solutions at that point, but just really taking them on a good co-diagnostic exam so they leave with at least a good understanding of what's going on in their mouth.
I love it.
That usually leads to,
It's so much easier just to talk to patients because, I had a 84-year-old break off the lingual cusp before. She has no idea what that looks like. She could feel with her tongue, but just the scan and say, hey, here's what it is. She's like, wow, I can't believe I can even see inside my mouth, and you can flip me over and all these different things that you can't do. But yeah, a photo or an intraoral photo can do that. But, when you can have that 3-dimensional image of just be able to turn it around, she just was blown away. So I think that's a marketing aspect too, I guess. Absolutely. Right?
Well, there's any question that we're competing with the people around us, and the better that you can kind of show who you are, but utilizing the tools effectively for both communication and increasing that PEP are all good things to do for your practice. And I think now it's becoming so commonplace more and more. I don't know what the penetration is, but it's not going to be long before half the dentists at least will be utilizing technology. And then the next question is at what level are you going to use it?
Right. So again, I'll be the young dentist. So I'm going to ask both of you guys this. Okay, this is a big investment. John, what does the future look like? Best you can guess. Like, is this going to get crazy exciting? Like, what could you foresee? Because you're inside on a lot of these conversations. What can we expect to see as a dental community in the next 4 to 5 years? What do you hope to see from a digital delivery?
Well, honestly, what I hope to see, and I'll just give you an example workflow that we're utilizing now that I want, honestly, my goal for what I do as a dentist, and maybe the legacy that I would like to leave behind is I would like to be able to take all the protocols that Dr. Dawson sort of created in terms of doing more complex dentistry and do this in a more efficient, predictable manner in the digital world. And so I'll just take an example of, say, a 10-unit case. Maybe you're going to do second bite across the top. The teeth are worn, the lower incisal edges are worn and irregular as well. So you do your treatment plan digitally, you do your virtual wax up, you find that you can equilibrate, you get the lower incisal edges looking like level with some bonding. And so you end up on the virtual articulator, being able to see exactly where you're going to go, what's going to happen on the bottom, where the incisal edges are going to be at the top, a lingual contour that is going to exclude the back teeth, but also has some concavity where you're imagining where the envelopal function will be. And at that point, you just basically print those two models. You make a silicone index for the top for your provisional, and you make a silicone index on the bottom just to capture the incisal edges. So a patient comes in, it's pretty much now analog. So you prep those incisal edges, you do your bonding with an injection molding technique, then you prep 4 through 13. You fill your provisional, your little matrix with a bisacryl, and you make your provisionals, and then obviously pack the tissues and get your scans for your final impression. So the analog part really doesn't change in the mouth. You still got to do that stuff. Now here's where it's different though, because when it went back to the lab, what we would always do is we would give them an impression of the provisional, and then they would cross mount the provisional model with the dye model to be able to duplicate all those contours. Now, the problem with that is, unless those two models were mounted perfectly in centric relation so they're interchangeable, you're going to get an error. Well, now what we do is, again, we've got that prep scan where all the teeth are prepared. Now what we'll do is slip on the temporaries, adjust them, and scan again. And what the lab does is they can superimpose one scan over the other, and they can perfectly copy those temporaries. In fact, there's no need to even really ever mount that master model. Like, it's not going to go on an articulator. They might print a model so that they can have, put it on something to check interproximal contacts and be able to look at it. But don't make no mistake, the design is going to come from your provisionals. And so, again, what's cool about that, from my perspective, is I spend time and do the digital wax up and get the teeth exactly the way I want it, and that drives the temporary. Well, that same model can kind of follow through the case if you want to, or you can do a new scan of the provisionals if you choose to do that, which is typically what we do. But that's kind of what gets me excited, because I think that a lot of the little errors that occurred when it got back to the lab, and now they've got bite records and they're trying to cross mount temp models and dye models. And after a while, I think labs just go, screw that. I'm not even going to do that. I'm just going to make the teeth the way I think it's going to look good. And then you get them back and they're too long or too far out. And then the case starts going back and forth and you hate your mother and all that stuff. So
I think it's so cool. I get so geeked about that stuff. And I just did a case 3 weeks ago, and I did both the analog and the digital way of capturing it. And I pretty much asked the lab, which one would you prefer me to do in the future? And they said digital in a heartbeat.
In a heartbeat.
So
I mean, you think about it from their perspective. They take two scans, they sew them together, and now they're rolling. And so the time it takes, and that's what's kind of funny to me with where we're at, because some of the labs I'm doing this with, they'll do that for me, but then they still mount the models because they still want to check it the other way. And I go, well, okay, that's fine. But what's going to happen is one time it's going to not, you're going to do the digital time and you're going to put it on the analog and something's going to look off. And they go, yeah, that probably will happen. And I go, so what are you going to trust? What are you going to trust? Well, I'm going to trust the old way. Why? Why are you going to trust the old way? It's probably off.
Right.
And I said, well, what you should trust is what I'm seeing in the mouth. Like when you send the case back to me, you need to get feedback from me is like, what is causing the least amount of adjustments? I said, let's do it that way. So let's do an analog one, let's do a digital one, let's do an analog, and I'll tell you the ones that require the least amount of adjustments. And I can tell you for sure which creates the least amount of adjustments, and it's the digital way.
I mean,
so back to your point, Kirk, for the young guy that's all this stuff, if you're a dentist that's interested in just doing kind of single tooth dentistry, maybe 2 teeth here, and really not get into the realm of doing larger things. I mean, even scanning just those cases is so much easier because you're scanning the prep, the opposing, and the buccal bite, and you're done, right? Those cases hardly ever see a model in an articulator. It's completely digital design. But if you want to get and start getting excited about doing some of these larger things, these are the protocols that are just going to get better and better. I mean, one of the things we still have to adjust analog is envelope of function because articulators don't chew. So we have to make a guess about what that lingual concavity is about. But if you really want to blow your mind, there's things being done right now with jaw tracking where we'll be able to put something between the patient's teeth, have them chew. It'll track that contour, and we'll have smart wax ups where the lingual contours of the wax up will be in harmony with that movement.
That's cool.
So that's that 5D modeling stuff that is not that far away. So you start thinking about, Kirk, 4 or 5 years, what I'm excited about now is companies are finally, and I've been beating on them for over a decade about the diagnostics, and companies were kind of looking at it through, just this little tiny lens that it had to be something that spit out something that like a crown or an inlay. They didn't understand the value of the diagnostics. Well, that's starting to change. And that really has me excited because now that they're starting to understand how important it is, they're starting to put money into it. And that's where, a little guy like me, when I first had these ideas, I thought I could have a little company and create these things. But when you start realizing the cost of all this code that has to be created, it takes big boys with a lot of dollars to design it. But it's fun for me to give them ideas.
That's just so fun. Can we transition here now? I want to talk about your book. I think
Yes.
Good thing to get on. I'm super excited to read this. I mean, it's just something that for those that don't know about your relationship with your son, I would love to hear that. So.
Yeah, so the name of the book is called The Cornell Effect, Principles Towards Happiness, Fulfillment, and Peace. And my son is 28 now. We adopted him when he was 1.5 years old, and he was a little crack baby that was abandoned at the Children's Hospital, spent 6 months on a vent, and was moved to a unit called the Transitional Care Unit, where my wife was his occupational therapist. And kind of during this whole time, when he first got there, they thought, be 1 pound 9 ounces back then. He was 23 weeks. I mean, they didn't have a lot of hope that he would make it. And so this unit was a vent dependent unit. Most of those kids never left there. So how she worked on that unit was sort of amazed me, but as she lost patients there. But during that first 6 months, there was something about him, and she was spending a little more time in his crib. He was sort of slowly, not really making eye contact, but slowly seemed to be more aware. And we had been going through about a 4-year period of time trying to get pregnant. And right in the middle of that 6 months period, we had gotten pregnant, and then she lost a baby. And so unbeknownst to me, Cornell and my wife's lives were kind of becoming inexplicably intertwined in her connection to him. And so she came home one night and she said, I think we're going through all this because we're supposed to bring this kid home. And I had been on that unit. I, was against the idea. Those things scared me. And so a couple months more by, I couldn't stop thinking about it. Anyway, long story is we ended up getting the training to bring him home with us. And, they sat us down on the day, told us he'd never walk, he'd never talk, he'd never make eye contact with us. And when we were done trying to save the world, that to call them and they would, come back and send him to St. Mary's Infant Home, which was where he was going to go. And so what's transpired since then is this sort of this amazing up from the ashes story of how he recovered and all the things that we went through and some near-death experiences. But I think what's most importantly is how he's always looked at life and never had a pity party. And his two sisters that came after him were, gifted, and things always came easy for him, and nothing's ever come easy for him. And he's never spent a second comparing himself to him. And he just gets up every day and puts a smile on his face and works at it. And so I wrote the book because it was cathartic for me, but I wanted people to understand how people like this have a place in our community. He's a different race. He's African American. So having a special needs kid who's African American growing up in our house, we have a view of the world that's pretty interesting. And I just think that there's just people sometimes put on this earth to inspire people. And I guess my wife's, when she had that feeling that we were going through all this to bring him home, I kind of felt like we went through all that. So I had to write a book. So I did. So this is one of the blessings of COVID-19. I've been working on it about 10 years. And one of the really cool things that happened here recently is he was actually a twin. And his sister was a little bit bigger than him. And it's pretty common that preemie girls do better than preemie boys. So she actually went home with the biologic family and was raised by the grandmother. And I'm not going to spoil it, it's in the book, but about 18 months ago, they reacquainted, and we just celebrated their 28th birthday together, and it's just the coolest. Wow. I was waiting for something. I could tell there was something that hadn't happened yet for me to finish it. And when that happened, I knew that was the full circle moment. And it's amazing, man. It's like you watch those two together, they finish each other's sentences. It's crazy. I mean, they talk every day. I mean, that could have gone so many ways, and it's been a really good blessing for both of them. So anyway, Cornell Effect, Principles Toward Happiness, Fulfillment, and Peace, and it's coming out Thanksgiving. So I'm excited about it.
Special kid. I can't wait. And we will have a link to that in the show.
Yeah, maybe the next time I come on, that'd be fun. The next time to come on is just talk about that, and I can get into a little bit more detail about some of the real principles and the stories that are in the book, because I do think that I just think there's a depth to this kid. There's some things that happen that are so beyond his intellect, and I think sometimes what I've learned the most from him, and you guys get this, but sometimes the people that have had the biggest obstacles are sometimes the happiest people on earth, because they don't sweat any of the small stuff, right? They just, when they're vertical and walking around, he's just looking at the world through just a big smile on his face, like he's freaking beat the odds. Yeah. And I think sometimes maybe in our world, I hate to say it, but I don't know think about my dad who went to World War II at 20 years old. I mean, sometimes when we have it easy, we don't really understand what, not easy, but you know what I mean? I mean, sometimes our obstacles aren't as great as maybe generations in the past.
Also, probably as a parent, you pull things from your child that most people on the outside don't see. So I think you probably are very receptive to a lot of the ups and downs that come through that, and the lessons that are taught. And
well, I can tell you right now, I never would have become who I was without him. He made me appreciate my gifts more, and he inspired me to work 10 or 15% harder. So I'm convinced I never would have taught with Pete. I think I would have been a good dentist, but But it's amazing early in your career, if you commit to another 5 or 10%, you don't really realize where that's going to take you in 30 years, right? I mean, and so that's what I want. I just want to make sure people get that. He certainly inspired me. So I'm hoping it inspires people to read it.
I can't wait to read it. It's going to be great.
Yeah. Awesome. 2 more things. I know we don't get you very, very long. I want you to talk about your podcast and where people can learn more about that, subscribe. And then I also want the 2 of you to talk about a place that's near and dear to all 3 of our hearts, which is called the Dawson Academy. If people are on the fence, they just got to go. Talk about those 2 things.
Yeah, so Go To Dentist podcast, just one word, Go To Dentist. They can go Spotify or they can go the Apple podcast route. It's similar. It's a similar format, but we're trying to really highlight people that are doing special things, and often people that, not always, but sometimes people they might not initially know. And what we're really drilling down on is what are the common threads that are making those people successful. I love doing it. It's like what you said, Kurt. I love doing it because I learn every time I do it. It just kind of fills me with joy. And so Pio Modi, who's one of our faculty, and then David Rice, who has Ignite Dentistry, we sort of take turns kind of hosting, and it's really, really fun. And of course, the Dawson Academy, I went through it right out of dental school and was lucky enough to teach with Dr. Dawson for 13 years, and again, past clinical director. But I think what we do there is we take good dentists, like good solid dentists that are doing great nuts and bolts dentistry, and we give them protocols to put into their practice to be able to handle more complex things, whether it's a wear patient or a veneer patient or, TMJ type patients, being able to understand why things are happening to patients and then give them protocols towards solutions. So, knowing why things are happening is huge in dentistry because it takes away the trial and error. And Kevin, you just went through it. So
yeah, I mean, having exposure to a lot of different realms of dentistry and the different philosophies, the one thing that I can truly embrace is the fact that anybody who I've known prior to going through Dawson had a very strong why and diagnostic capability. They knew exactly what was happening, the understanding of what was going on. And I just felt like that was the most critical part. And that's why I jumped in the academy. And I took so much away from that. My associate, she's going through right now. She just came back last week and said, I think everyone thinks we're just drinking this Kool-Aid, but the Kool-Aid tastes great. So I was just like, no, it's true. There's such great people there. They all have a passion and a story behind why they do things. And even reading Pete's book, I was so blown away by the number of principles and things that he brought into my life without ever meeting the guy. And it's the teachings that ACT Dental talks about. It's the teachings at the Dawson Academy and the life principles that come from that. I really just took so much away from that autobiography that I was like, this is just really up my alley. And I'm so grateful for everything that Pete Dawson did for me without even having any effect in terms of a one-on-one connection. So I can't promote the Dawson Academy enough. I can't promote your podcast enough too. I'm an avid follower of the Go To Dentist podcast. And I think that's something that your guests that you've had on there and the questions that you pull from people, you really get the most out of every guest. And I think it's such an enjoyable way to drive to or from work. And I've really enjoyed every minute of it. So
yeah, I love podcasts. I do. It's fun to do them, but I spend so much time in the car going back and forth to the lake house. And it's just nice. I used to listen to the news. I'm so glad I don't have to do that anymore. But anyway, that's like death now, unfortunately.
Yeah, the crazy part is we're meeting all these people. I've never met you in person. I think this is the wild time right now. It's something that's so funny that we're meeting all these people and becoming close with everyone. But I hope at some point
we'll get past all this mess soon, I hope. And and that's what you just have to. But again, I think it's cool that we've still found a way to be connected through all this. Because if you would have told me we hadn't met, I would have had to think about that because I feel like we've met.
Exactly right.
Crazy.
Well, I'm going to be there officially when we do this because when it's all over, John is going to invite us up to his lake house. I just told you for that. Yeah. So we'll hang on with Cornell.
Maybe we could do one like together at the lake house.
That'd be really fun. I've only seen photos of your fire pit, but it looks awesome. It just looks like heaven.
Awesome.
It's awesome, man. It's awesome.
We'll do a book review. So
Yeah.
Awesome.
All right,
buddy.
guys, this has been fun.
All right. Well, stick around for here for just a second. If you guys are listening, just do us a favor and you enjoyed today, share this with your friends. Keep sending us suggestions for things that you guys want to see, not only from John, but other guests. And wherever you subscribe, make sure you sign up so we can keep bringing you great stuff. And until we talk to you next time, or we see you next time, keep watching the Best Practices Show. You guys enjoy the rest of your day.